Good morning. Welcome to the Department of Medicine Grand Rounds. On this day back in 1971 was the death of Arne Tiselius. Arne Wilhelm Karin Tiselius was a Swedish biochemist who won the Nobel Prize for Chemistry in 1948 for their work in electrophoresis. And in fact, he and his group were the ones who confirmed the existence of the four groups in serum, protein groups, alpha, beta, gamma, globulin, albumin. He did a lot of work in separation of proteins using gel filtration and so forth, but that was his greatest effort. But today our speaker is a member of the Infectious Diseases Division, ID. And so we remember two important people. Number one is Baruch Banasarraf. I want to say that again, I like saying it. Baruch Banasarraf was a Venezuelan-American geneticist and immunologist who studied the genetic basis of immunologic response to autoimmune diseases, but also infectious diseases. And he received and shared the Nobel Prize in 1980 with George Snell and Dowsett for actually describing how genes that were related to certain surface proteins on immune cells actually were responsible for the communication between immune cells that actually are important for activation and regulation of how the immune system works in response to antigens. So that was very important. But also want to remember Albert Calmet, and you should remember Albert Calmet because with his colleague Camille Guerin, they developed the anti-tuberculous vaccine, the BCG, the Bacillus Calmette-Guerin. And he was a French physician and bacteriologist who died on this day in 1933 and who established a center called the Louis Pasteur Center in France because he was a pupil of Louis Pasteur. So with that, I leave you with Dr. Julio Ramirez, who's going to introduce our speaker of the day.
Good morning. It's a pleasure for me to introduce then Paula Peyrani, one member of the division. Paula is originally from Argentina. She finished medical school at the University of Buenos Aires. She also did the residency there. Then she moved here to Louisville and completed an ID fellowship with us. And she's been part of the faculty. Paula, as every other member of the ID faculty, everybody has, according with the day of the week or according with the hour of the day, they have different responsibilities. But I may say that one of the primary responsibilities has been that she runs our Ryan-wide program, and she's going to explain this. But Ryan-wide is a federally funded program that takes care of more than 500,000 HIV patients in the country. And she's the principal investigator of these grants, and the grant Ryan-wide part B, C, and D. Then she's the project director of the grants, and based on her experience during the year with these grants, and what we want to do in our global health clinic, hence the title, Our Journey into Patient-Centered Medical Care from the Ryan-wide program, that probably the person with the best experience is Paula, to our global medical home. And with this, Paula.
Does it work? Can you hear me? I speak loud anyway, but. Well, good morning, everybody. This will be my first time here, so hopefully I'm not going to mess it up. So the idea of this presentation is to go through actually three main areas that you can see here in the outline, all gearing really towards going through the model of patient-centered medical home. So the first section will be focusing a little bit on the history of how patient-centered medical home started and what has been done so far, and what the components of this model are. In the midsection, we'll be discussing the Ryan-wide program actually as a model for central medical home and how the HIV clinic funded by Ryan-wide programs have been working within this model for many, many years, even many times without really knowing what it was being done. And then little bit on the University of Louisville Global Health Center and the Global Medical Home and our vision on how this could be implemented and how it's going to work. So actually, although I think this is now in healthcare a little bit happening more recently, actually the first time that this model has been thought or discussed was in 1967 when the American Academy of Pediatrics proposed this type of model to care for children with special needs and chronic diseases. But it was not only until 2007 when these different organizations and associations published a manuscript talking about the principles of patient-centered medical home and describing the different components that were included in this model. It was in 2008 when the National Committee for Quality Assurance, this is the main organization providing accreditation for healthcare, developed the Physician Practice Connections and the Patient-Centered Medical Home Program. And actually, in 2010, it's been reported by this organization or association that nearly 77 healthcare providers and more than 15 locations have received recognition as a patient-centered medical home. This process of credentialing or accreditation, it's very tedious and long, and it's not easy to accomplish. So in Kentucky, as far as I'm aware, there is not really any center that is accredited as a patient-centered medical home. Looking at a model of patient-centered medical home and the components, of course, the patient is in the center. But then the model includes a team approach, comprehensive care, coordinated care, access to care, quality of care, and safe of care. And all these components are really developed and thought and designed with the goal of provide care in an individualized manner, basically looking at what the patient needs, what that family needs, and how that can be implemented by all the different providers and people assisting that person. So if we go through the different components, and I'm just going to briefly mention kind of the goal of that area, the patient-centered care, of course, is oriented toward the whole person and in partnership with the family. So basically, we are not caring for the patient only who comes to our clinic or the hospital, but then we take into partnership the family and make them involved and participated in the patient care. In the team approach, we tend to do this daily, but I think the way that the patient-centered medical home functions is really having a team approach that is very well organized. So it's provided by a team including healthcare professionals, but also other members that really, the member that gets included in the team is driven by what the patient needs. So for some patients, the team may be a small group of a physician or a provider with nursing and clinical pharmacists versus in a different group, in a different patient with a more complicated situation, you may be including lawyers, social workers, as care coordinators, for example, and any other component that might be needed. In the comprehensive care, I think the word probably says it all. The goal of patient-centered medical homes is to provide comprehensive care, including those services that are really defined, designed, and provided based on patient needs. So again, it reiterates in each section that it's not one service that fits every patient, but different services fitting one patient in particular. The coordinated care is a key component, and the people assisting this process are key components or key players in establishing the connections among and between the different components or people providing or assisting in that component. So really the care is connected and supported in all settings, and this is not including only the clinic where the patient is being seen, but also the medical neighborhood. And medical neighborhood is probably really a new terminology. I don't think that this was established in 1967. And what it relates to medical neighborhood really is that the clinic where the patient is being seen by the team participating in that care, it connects the patient and is connected with all the other settings, hospitals, other clinics, specialties, schools, depending on what the situation is, and this is included in this neighborhood. Access to care, a key component to all of this, and really the access to care, although seems pretty obvious, it's very difficult to accomplish, a wide access to care, because really this access to care is defined by what the patient needs, what the patients need, and not what we have available for the patient, or that would be the goal. So many times we end up providing what we have and what we are capable of, but really goal would be to define what we have and what we can offer based on what the patient needs. Quality of care linked to all of the other ones, and particularly with SAFE. This is something that I'll be discussing a little bit more within the Ryan White section, but the ultimate goal, of course, is to have an ongoing real-time assessment of the quality, and the quality also includes the needs of the patients being cared in that setting to allow patient-based decisions. Sometimes your goal or your estimations might change over time, and if there is no quality being done and assessing all those changes, you might miss what may need to be done. Within safe of care, of course, the goal is to assure a culture of safety, not only for the patients, but also for the families, the healthcare workers, and any other clinical staff that might be participating in the care of that patient. So moving on into Ryan White program, this is probably what I'm going to take most of my time. My idea here is to show you what the program has and what we do here in the clinic as part of this program and what we think is really useful for a patient-centered medical home. So as a background, whoever doesn't know what Ryan White is actually this kid, or was. He was born in 1971, but he was sick and got diagnosed with AIDS at the age of 13. And he died when he was 13, and he died when he was 18 in 1990. So his mom actually worked very closely and pushed, probably many people would say, the Congress to pass the Ryan White Care Act in 1990. And this was passed 4 months after Ryan White died. So the name Ryan White that you'll hear, it's in honor of this kid. He was a hemophiliac, and he contracted HIV because of blood transfusion at that time. CARE stands for Comprehensive AIDS Resource Emergency Act. So this was in the midst of the epidemic when everybody was dying, and there were no resources to care for these people. This act was reauthorized 4 times since 1996. Since then, in 1996, 2000, 2006, and 2009, and you have here the last fiscal year, 2014, the budget was $2.3 billion. So I'm going to try to quickly tell you what the Ryan White program entails and where this money more or less is going to. The Ryan White program has 5 main different parts before they were called titles. Part A, B, C, D, and F. I don't know why there is no E, but there is no E. Part A is basically money given to big metropolitan areas significantly affected by the disease. Louisville is not considered that, so we don't have Part A. Part B is actually given to states, mostly health departments. And the funding for Part B goes to the Drug Assistance Program. Here in Kentucky, you will hear our patients talking about KDAP. That's the Kentucky AIDS Drug Assistance Program. And emerging communities. So under Part B, there are different services being provided. Many times, besides the money for drugs, some dollars or pretty many dollars go to the care coordination programs. Usually every state has one program. We have the Kentucky Care Coordination Program here also in Louisville, and then it's divided in different areas within the state. Part C, it's the main grant providing primary health care and other services. Part D also provides primary health care and other services, but the Part D program is mostly to outreach, and it's being seen as a more comprehensive care, including women, infants, children, and youth. So basically what HRSA did was to divide these 2 grants, and then here you group males who are over 24 years of age, and here you have women, infants, children, and youth, defined also by the males less than 25 years of age going here. And this is from more a budgeting perspective. Part F includes different programs that are provided to the community and to the patients. They fund innovative models to provide and improve access to care. Here you have also education programs that are being provided, and in Kentucky, UK is the one providing education and training under this funding opportunity. Dental programs, the School of Dentistry has Part F funding for HIV patients and providing dental care, and this is for minorities with AIDS, so basically mostly African Americans. The Ryan White program actually is managed and run by the HIV/AIDS Bureau that belongs to HRSA. This is Health Resources and Services Administration that is within the U.S. Department of Health and Human Services. And it's a grant, as Dr. Ramirez mentioned, it's actually what we could call a service grant. It's not clinical research done within the grant. And what we provide with this money basically is care for the patient, support, not only medical but non-medical, teaching, education, and access to research. And that's what is expected from HRSA, from all the clinics funded by Ryan White. I highlighted here the funding that we manage, the Division of Infectious Diseases. We have Part B with a subcontract with the state, Part C and Part D. As I said, there is no Part A in Louisville. And then Part F, it's managed at the UK level for education and the School of Dentistry here for dental. There are other 3 clinics and 3 programs funded in the state. One is in UK, another one is in Henderson, and the 4th one is in Paducah. So you will probably wonder why are the Ryan White clinics considered to be an example of primary patient-centered medical home, although they are not accredited as patient-centered medical home directly. So if you remember the figure that I presented at the very beginning with the different components of this model, I'm going to try to walk you through each component, what the grant proposes and what we do in the clinic, so you can get an idea of what it's currently being done and what we're hoping to get to be doing in the future. So as patient-centered medical care, of course, usually, and particularly years ago, the team that was kind of created for caring the patients, it was managed and led by an HIV expert. Nowadays, this is a plus-minus, and it depends really on the clinic. There's always HIV specialists in the clinics, but more and more primary care providers are assisting in the teams, and sometimes the primary care providers are the leaders of this team. So the HIV expert manages or co-manages the patient's HIV primary continuity care needs, and of course identifies the subspecialties that may need to be the patient referred to for provide further care. There's always nursing staff, and this could include registered nurses, medical assistants. It's considered critical to have clinical pharmacies as part of the team. And the pharmacies mainly for HIV care identify drug interactions. As you might know, many of the HIV drugs have plenty of interactions with everything else in the world, including herbal products. Adherence and medication management. And of course, mental health, which is another key component of the health of these patients and probably all of us. So if you consider the patient as the center of the care, we have infectious diseases and internal medicine physicians and providers in the clinic. Faculty from the Division of Infectious Diseases are all of them. Nursing staff, clinical pharmacists from the University of Louisville Hospital and from Sullivan, and then mental health providers. Comprehensive care, I mentioned before, that is another, it's a key component because basically with this goal, you provide as much as you can, ideally under the same roof. With patients with chronic diseases in particular, but I guess many of us, having to bounce from one place to the other to see every different specialist that you have to see consumes most of your life. And for HIV patients, particularly nowadays, that people are living longer, these people are growing and becoming elderly, and their comorbidities are taking over much more of their care, much more than the HIV itself. So they end up being referred to many different specialists with many different medications, polypharmacy, and the complications of appointments and work and traveling and all that. So the idea is that in the same roof, as much as possible, you include care coordination, obstetrics and gynecology, pediatric care, medication adherence support, mental health services, and ideally on-site pharmacy and laboratory. Of course, you can expand as much as possible, and that will be the ideal situation, so you could also include oral health, ophthalmology, oncology, dermatology, neurology. I would probably add here pulmonary care and cardiology. These are the main comorbidities that our patients are dealing with today. So if we expand on our organization in the clinic, besides what I already mentioned, what we are able to provide either within our own division or in collaboration with other schools or divisions is dentistry, with the School of Dentistry, legal aid. We had a paralegal person coming to our clinic once a week, every afternoon, for free actually, to assist our patients with any legal issues that they might need. Any other specialties, at this time we don't have people in our clinic providing specialty care, besides mental health, I already mentioned, but then we are trying to develop collaborations with other clinics and groups to have, I would probably say, a fast and easy referral process for these patients. Primary care, with the person that we have at the internal medicine physician that we have as faculty in our division, it's not enough, of course, to provide primary care for all our patients. To give you an idea, we have around, at this time, 1,800 patients total in the clinic, HIV positive, and the goal is for them to all have primary care, particularly those who have insurances that now require primary care for many ordering tests and referrals, so this is becoming a critical component. Research, that actually, it ends up being a really patient-centered research. The research being done, particularly in our division and then in the clinic, is really to focus towards the patient and what the patient needs. And care coordination, that I'm going to expand a little bit more in the next few slides, but this is, I mentioned already, this becomes critical. Coordinated care, the care coordinators are the key. There are many things that we could do ourselves in a much more complicated way, and we just pick up the phone and call the care coordinator, or send a text, or send a message through Allscripts, or stop by. They are located 2 blocks away from the clinic, and they always have 1 or 2 people on site for walk-ins. They are the ones linking the patient, the system, the clinic, the neighborhood, the pharmacy, the laboratory, other organizations, other agencies, assisting people living with HIV/AIDS. So really, it gets very, very complicated when they are not helping with the needs of the patient. And okay, the goal of the coordinated care is to meet patient needs across a variety of clinical specialties and other support services. The Ryan one really has a history on providing coordinating medical and non-medical support services. And I'm going to show you the next slide. Basically, I try to put here how I feel that this works. The patient is in the center. The patient has different needs and works or interacts with different people. So people from the clinic, providers, nursing, front desk, staff. Patients need medication and have other medical needs. The patients really need mental health many times. They all, or 90% of them, end up having some type of non-medical needs. And then, of course, we have the clinical pharmacies helping with medication. So there are interactions with the patient and everybody else, and among different other areas. So at this time will be the patient communicating with everybody, trying to figure out how to get the HIV specialist talk to the pharmacy, or the HIV specialist talk to the specialist, or to have the HIV specialist getting the note from the provider in a different clinic, in a different group that saw the patient. So at this time, really in this setup, it will be the patient mostly taking care of this. So this is how it happens in our system, in the clinic. The care coordinator works closely with the patient. And then the care coordinator is really the person interacting with all the different areas closely. And it's worth mentioning here that not all the patients in the clinic are under the care coordination program. The care coordination program is part of the Part B funding that I mentioned before, but there is certain criteria that the patients need to meet to be part of the care coordination program. So I would say probably if we have around 1,800 patients, 1,200 of those patients are under the care of, or the assistance of care coordination program. The remaining ones, we in the clinic are doing this. So it's the physician or the physician assistant or the nurse practitioner working with the pharmacist, with the laboratory people, with the care coordinator, although the patient may not be in the program asking for help. So this is a very complicated and tedious work, but really I think the ultimate outcomes are very, very good. If you think about the comprehensive care that we are able to offer through all these different funding sources and efforts, besides what I already mentioned, care coordination program actually connects the patient with all these different opportunities that are coming and are available in the communities through different funding sources. We can assist with housing and emergency housing. KDAP, as I mentioned, is the drug assistance program that is managed by the Department of Health at the state level and from within UK as the pharmacy. Food pantry for those who need to eat and cannot afford food. Assistance with finances, that could be co-pays, insurance, and all those. So they were the ones, the care coordinators actually were the ones when Affordable Care Act was implemented and people were promoted or suggested to sign up. They were the ones for our patients who were helping patients with exchange plans and providing assistance and guidance for some of them. We can assist with transportation and sometimes paying for cabs, depending on the budget and how much money we have left. Insurance, as I mentioned, of course, substance abuse referrals and screenings, and then counseling for patients and partners and families and friends. Access to care, I think all of the other components definitely work better if the access to care is wide and simple. In HIV, like many other comorbidities probably, but for HIV, and you will read it over and over and over, it's critical linkage and retention in care. And many of you have heard about the continuum of care, of cascade of care. I'm not going to go into that, but that shows basically how many are infected, know that they're infected, diagnosed, into care, retaining in care, and have viral load suppressed. So this is critical for controlling the epidemic probably and keeping people healthy. It really addresses within the Ryan White program unmet social needs in particular, because social needs are mostly the main barrier to be in care. Medication adherence support, of course. Electronic medical records are a key component and tool for this comprehensive care and patient-centered medical home. And this is another barrier, I would say, probably to make sure that things are all on the same page. And the ultimate goal, of course, is enhancing quality of life. So Ryan White program, in our clinic, we implemented this access to care through different fundings and different resources. So there is an intake nurse. At this time, if you call the clinic for an HIV referral, there is an intake nurse who will take your referral, and we will probably be able to see that person within 24 hours if the person can come to the clinic, sometimes on the very same day. The intake nurse is the person who really sees the patient, gets the first vitals, medical history, and orders the labs, and follows the patient if the person doesn't come back when he or she is supposed to come in the clinic. So the intake nurse ends up working as a care coordinator many times, initially until the patient is established within our clinic system. We have walk-ins. There's always somebody who will be seeing the patient. If it's not the physician or the nurse practitioner or the physician assistant, it will definitely be one of the clinical pharmacists or the nurses. Actually, within these walk-ins, many of us don't have full-time in the clinic, so we have half-a-day clinic, but usually we are able to come to clinic if one of our patients shows up. We many times are able to see the person, or we are available on the phone for the nurses or somebody else to call if there is a problem and they don't know exactly what to do. There is a triage nurse or somebody backing her up who manages all the calls from the patients for acute problems, and usually we get to see them on the very same day as a walk-in. But we also had walk-ins for newly diagnosed people who were discharged from hospitals and sent to our clinic to make an appointment. So the goal is to try to see those patients as soon as possible, at least for the first visit. Oral screening is now being provided for free and scheduled 1 day a week in the afternoon in our care coordination program that is in the Med Center one. So many patients are stopping by, and then they get the screening, and then from there they already get the appointment to be seen within the School of Dentistry and the different locations that they have. Clinical pharmacies, at this time we have 5. Not everybody is full-time, of course. We have 2 clinical pharmacies from the University of Louisville Pharmacy. They switch, and they cover every day in the clinic, one or the other. And we have, actually we have 4 pharmacies, 2 from UofL Hospital and 2 from the College of Pharmacy at Sullivan as a gratis faculty within our division coming. One is in the HIV clinic, 2 days a week, and then the other one is the clinical pharmacy with the bone and joint service, rounding in the hospitals and helping in the clinic. The care coordinators that I mentioned, this was recently funded. It was previously managed by Volunteers of America, and in the last competitive application, we submitted a proposal and won. So we've been doing care coordination since the beginning of, actually the end of last year, and I think it's working really well because it's integrated in our clinic. We also provide care coordination for our other patients who are not seen in our clinic, but by ID private physicians. But if they meet criteria for care coordination, they come to our clinic. And mental health therapists and psychiatrists, this is an area that is becoming more and more critical, and it's lacking a lot on resources. We don't have a lot of people who can provide mental health now. And actually, we have 1 person and another one volunteering, not for HIV necessarily, but as a therapist, we have only 1 person. We refer them out to 7 counties and other organizations who can assist with mental health. Quality is an integral component of Ryan White program and clinics. We actually have to report to HRSA on quality every year. The goal is to evaluate and monitor the clinical processes. So actually, the quality projects that are being done are not mandated which ones should be done by HRSA. They have a list of projects that you can pick or indicators that you can follow, and the clinic is supposed to pick the one that is more representative of the needs of their patients and their setting. Of course, we're evaluating patient outcomes with some of these indicators. Effectively manage limited resources. Another thing that HRSA is expecting clinics to do and programs to do is to periodically evaluate your budget and your work plan, what you said that you were going to do. So if you feel like there's something that needs more attention that you were not planning on that, you need to rebudget or rearrange money to make sure that you cover that. The same way, if you're not using fundings that you were supposed or thought that you were going to be using, the goal is that you change around things in order to redirect those fundings. The key component is patient involvement, and HRSA talks about consumer involvement, and they are expecting us and all the clinics really to have either a consumers group where the patients get involved in the decisions in the clinic. We had that before, really, where we were not getting more than 30 to 40 patients in the meetings out of the 1,800. And we felt that it was not really representing all the diversity that we had in the clinic. So last year we moved to surveys that we provide in the clinic when the patients come, or via email for those who use emails. And that way we get a sense of what is needed, what's happening, and what things need to be changed. Within our clinic, really, HRSA, it's not that it belongs to HRSA, but it's another agency working with HRSA in quality, and it has been developed by the New York AIDS Institute. So this is an organization that has different leaders going to the different states, and actually 1 person covers different states. And we have one here in Kentucky. We meet quarterly, and basically the goal of those meetings is to discuss the problems, brainstorm on the issues, and try to find solutions. So one of the last meetings, all the clinics, of course, are facing the same problems. No-show is a huge concern, not only because there is appointments that are wasted and people waiting for patients to come, but then that puts the patient out of care and with the possibility of HIV getting not well controlled. So it was a brainstorming on what to do. Patients have a phone, but the phone doesn't work, or they change the phone numbers and they don't call you. So that was very helpful in order to develop a proposal and solutions to try to improve at least that area at that time. So what I put here is some of our quality. We have more than this. Pap smear as prevention for women, it's something that we've been trying to do lately, either doing it in the clinic or anywhere else, but trying to get the report, and this is where the electronic medical records become critical, because getting reports from other clinics, it's not easy, and that's what HRSA takes, the documentation of the PAP being done. So our goal is to be 85%. We are far below there, but trying to implement different tools and systems to get this number improve. And actually, you can see here who is in charge or who is participating in each quality. So we test annually for syphilis regardless of what the patient says. And we were surprised many times when they were swearing that they had not had sex and their PR came back positive. So we asked just in case what we've been doing, but we always order once a year. And then viral low and CD4 at least once a year. That is actually more to report to HRSA than what we are doing in the clinic. This is a new CDC recommendation over the last 2 years or so, annual screening for men who have sex with men, checking for chlamydia and gonorrhea once a year. And we do rectal swabs, urine, and oral swabs, so the 3 sites. We've been surprised as how many positive tests we've had with no symptomatology. So this is something that we keep doing, although we are not very happy to do that, but it's happening. Comprehensive intake, new patients, and then follow up on no-show appointments. The way that one system that we developed for quality to make sure that things are being done and they don't get overseen or anything like that, we developed a cover sheet that goes in at the front of the paper chart where you get the medication list. And in that face sheet, you have the laboratories that are supposed to be done or that you're asking. So the nurses check what things need to be done. If there is an RPR missing, or the pap smear, or the HCC and chlamydia screening. There is a vaccination that they also check that is needed for that patient, any other referrals that you want to put. And then at the bottom, you put when you want the patient to come back. So to finish this and to give you the whole perspective beyond the HIV, and using the HIV as the model for patient-centered medical home, this is what we are currently doing in the 550 clinic within the global medical home. The HIV clinic, as I mentioned, we also do refugee health clinic, and many of these areas have been already presented here in Grand Rounds. The vaccine clinic, but this is for anybody, not just our patients. Anybody who needs vaccination can come to our clinic with an appointment and get the vaccine. International travel clinic, telemedicine clinic that at this time is only being done, it's an agreement with the Department of Corrections in Kentucky, and we do HIV care for all the prisons in the state and Louisville Metro Jail. We do general ID, of course, bone and joint, civil surgeon for people going through the process of establishing permanent residency in the States, the latent TB clinic, at this time for our patients. We are taking over this. And then primary care clinic and outreach clinic that is actually going to patients' homes. So how is that we get to do all this? So if you think about the figure with all the different components, some of these things are currently being done or implemented, and some of them are basically hoping for the future and planning for the future. The self-scheduling, which will remove a lot of time from the front desk of answering phone calls and trying to set up appointments or changing them or following them up. Extended hours, I already mentioned that many of us go back to the clinic if there is a patient that needs to be seen or if there is support that is needed. But then this is going beyond that and then actually being able to see patients after 5 p.m. on weekdays and then on weekends. We are not doing that yet, but it's coming in the future. Yeah, but it's coming in the future. Home visits, part of the outreach program probably. Again, sometimes we have done this for some HIV patients also, but definitely trying to implement it in the future. On-site pharmacy, but full pharmacy, not just the clinical pharmacies. The consumers group, as I mentioned, for the HIV, but for the whole program. And then community groups. So this is getting advisory groups from the community. The medical neighborhood that I already alluded initially within the patient-centered medical home and trying to establish the connection with all the other clinics in the community and hospitals in the community and services provided by in the community and helping patients navigate through all those different settings. On-site laboratory, and then getting the certification as a patient-centered medical home, hopefully in the future, and definitely getting the global medical home as part of the University of Louisville Global Medical Home, and I'm going to show you something a little bit later. Within the UofL Global Medical Home, basically the goal is to take the patient in the mind, the body, the spirit, the holistic approach to healing, and then include all the different schools and departments that university has, and basically, of course, this can be done because we are within a university setting. So then it's not only the medical component of assisting the patient and caring for the patient, but of course, law, social work, business, arts and sciences, athletics, education, public health, engineering, music, and then what we, I guess, probably all would expect, dentistry, medicine, and nursing. So this will be something that will be coming, hopefully, within our global health. And at this time, we're being able to do many of these things that I showed you, because in our team, we have 137 employees working in all these different areas that I described. Just going quickly, of course, I'm not going to name everybody, but to show you the different areas, we have physicians and medical providers, the clinical pharmacists, the mental health providers. And within the 137 employees that I said, of course, beyond that, there are a lot of volunteers that I'm not listing here, but helping with research, with patient care, with non-medical issues. Nursing medical assistants, the care coordinators within the Part B from the Ryan White program, the administration on these different areas. Clinical research, it took me 3 slides because of the team that we have doing. And the clinical research, again, remember, most of our things are really patient-centered research. So you have research in the HIV component, research in refugee health, research in general ID, in bone and joint. Laboratory and biorepository, now working in some of these areas. The goal is to move this to a broader component. And keep in mind that kind of in the same tone as the other figure, but the Global Health Center will be, and we hope that our Global Health Medical Home will be part of the neighborhood. And the neighborhood will be the University of Louisville working together to assist patients. So you have all the different schools and departments, all the different areas that we could think and put together, and all the deans in the different schools had been approached and agreed on participating in this project. And I guess you probably are wondering, and what many people wonder is, how can this be done? With, which money would you use? And how would you pay for all these resources? So at this time, we feel, and actually probably there are many more possibilities, but I can see 4 different things definitely to assist with this. Of course, patient service, billing, and reimbursement, which is critical, and we many times don't pay good attention to our notes and how we write and what we put and how it's being billed and how it's being followed. But definitely reimbursement, and Ryan White has a huge focus on that now with the Affordable Care Act. It's a critical component. Education and teaching. In our clinic and in our program, actually, we have established connections with different schools within the University of Louisville, but also outside the University of Louisville, where we have students coming to train and to teach, but also that brings faculty who provide service in the clinic. Pharmacy is one example. We have different students from different schools. Social work is also another example. Nursing is another example. Nurse practitioners, physician assistants, they all help, and they also learn. So that's another tool or way to assist and improve. Definitely research and patient-centered research. All these grants and studies that we are doing, providing and assisting patients, bring money to the program, and we can use that with bringing more employees or more resources. And finally, philanthropy, definitely. And that's what I think Dr. Ramirez and Dr. Carrico have been working a lot lately with this vision of the global health medical home and the buildings. At this time, they are having meetings to build the first building and to get $15 million to get that built. And that is going to come from philanthropy. So there is no one way to get the money. There is no perfect way to get the money. There is no perfect way to do this, I think, or best way to do it. This is an effort and really having the wish to get this done. Thank you very much.
Thank you, Paul. So you have described to us the patient-centered medical home based on how we've done it for HIV. What is the average lifetime age of an HIV patient these days?
Today? So half of the population is expected in the next couple of years to be over 50. And the life expectancy really, it depends on the time of diagnosis and how advanced the immunosuppression is. There are studies showing today that really somebody being kept in care, on treatment, taking medication, having HIV control, the life expectancy could be the same as not having HIV.
The reason I ask, and this is a delicate discussion, but with HIV becoming a chronic illness, it might be no different than diabetes, COPD, congestive heart failure, renal failure. And as you suggested here, there's $2.3 billion invested in Ryan White, and another $15 million that you're going to get tomorrow for the building.
Yeah.
How do we continue to justify that investment in HIV and not necessarily in COPD, renal failure, congestive heart failure, mental illness, and so forth?
It's interesting because we've been discussing this for the last, actually I've been as the principal investigator and the person kind of dealing with the grant from the budget and the work plan and how things are being done. That's my fear, because I know that HRSA is coming with this thing of, well, most of the budget is on salaries. That before we had 40%, 50% patients being uninsured. And Ryan White program is the payer of last resort. So anything else that can be paid somewhere else or taken care of in a different way, it should. So at some point they're going to ask all the clinics to reevaluate how the program is being managed, and they're not going to allow you to have 10 people, between providers and nursing to be paid by the grant when the insurance are covering for this. So the way that I think that you justify what you get from HIV and you try to implement it, and actually, I don't think HIV is a chronic disease now, but I think the HIV itself is not the main chronic condition that affects the patient. It's all the other comorbidities, because assuming that you don't count the inflammation as producing the comorbidities. But to me, it's justifiable for any other comorbidity. The question is how you make that happen. I think what I mentioned is definitely one way to try to get different people and team players involved and collaborate. There's some degree of collaboration that is no charge at some point. But then, funding sources, there are several, although not easy, but there are several grants that are for this type of things. HRSA is the main agency within the government really funding clinics and places for optimal access to healthcare, particularly for those who are vulnerable or minorities. It's an effort, and it's totally justifiable.
Questions?
Yep. Hepatitis C. So for the first question, the Scott County in Indiana outbreak that happened at the beginning of this year, that was an interesting experience. So this is a very small town where people live and basically don't leave the town overall. They don't have specialists. They have a nearby hospital, but they basically have primary care and nurse practitioners. We got some of those patients. I think the final number that the CDC has for that outbreak is around 180-something patients. Most of them, Hep C was the main infection, but then many of them were co-infected with HIV, and we got the HIV ones. Actually, we saw just a minimal number, around 12 patients were referred. More patients were referred, but 12 came. And most of them didn't remain in care. That outbreak was interesting, and I think it was very confusing. You had Indiana Health Department, Scott County Health Department, Clark County Health Department, the CDC. The CDC was changing teams every week or every 2 weeks for the field team. I was on conference calls with the laboratory part when they were investigating the linkage between the patients and trying to find patient zero or the source. We had a couple of patients from that area that were part of the outbreak, but that we had seen in the clinic before, and at the time of the outbreak, their viral load were in the millions, so they could have perfectly been transmitted. I haven't seen really an official report on how the CDC thinks that the outbreak happened, how they explain, because these people have been using IV drugs before the outbreak. So how is that they are explaining this number of patients being diagnosed that were not diagnosed before. I don't think the CDC finalized the investigation yet. What we know so far, and I've been trying to establish a system with the Scott County and Clark County with the clinic and Dr. Rauram as the medical director of the clinic, it has been very difficult to pinpoint at one person who is the leader organizing things, definitely. And so far, we haven't been able to establish anything. Indiana University helped at the very beginning. Then there were other organizations coming from California that I don't know how it worked. The primary care there, Dr. Cook has been seeing some patients, but then not everybody wants to see Dr. Cook. I think it's still in nothing, honestly. Regarding the assistance program for hepatitis C, we heard that rumor. KDAP, including Hep C treatment in their formulary. I don't think anything is established yet. It makes sense, again, that would be the other infection that definitely a system like Ryan White will help. But I don't think anything is really official.
Other questions, comments? Is there an interaction between your group and the microbiology group? In this era where there's questions about, let me backtrack a little bit. There's a lot of anxiety going on in multiple centers across the United States about the emerging changes occurring in healthcare. The curriculum of medical schools are also changing, and students are being asked to engage in clinical practice very, very early on. Basic sciences are questioning what is our role now that the traditional lecture is going to be gone. And there's multiple groups that are beginning to align the clinical enterprise with basic sciences. In your case, would be microbiology, I would think.
Yeah.
But there could be others.
Mm-hmm.
How is this effort supported in any way other than identifying a bug by the Department of Microbiology?
We haven't had, we work with microbiology in the hospital, and that's our partner for the clinic from a patient care perspective. That's the laboratory that we use, and we have a very close interaction with Dr. Snyder and his group, and anytime we have a problem with anything, even though it may not be their area, we call them, and they respond. With the school itself and the microbiology department, we haven't had really much interaction besides, not micro, but students having a rotation in our clinic that is still elective like the residents. And that has been growing through, I think I started that when I took over the clinic in 2012, or restarted that, trying to open the clinic for those purposes. And we're having more and more students. At this time, it's Dr. Rauram taking care of that, but definitely. I think a rotation in this type of clinic should be mandatory because that affect any specialty that you do.
I understand. Any further comments, questions? If not, then have a good Thursday.
Thank you.